So, yeah. So I have got only 28 minutes to fill in two presentations. So that is all right. What we try to achieve in 16 hours of skill transfer in critical care, it cannot be achieved in 1 hour. So I better, concentrate to just 15 minutes, and same about 8 hours course, which we do for critical appraisal of literature. Why do you need to do that? Regarding, I'm going to talk about two things here. I've already alluded to. One is why it is necessary for all the transplant surgeons, nephrologists, all the medical doctors, or in any specialty, need to really have skills of looking after sick patients. We don't want to just leave them to the anesthetists or to the ITU consultants, ITU registrars. We all should have skills. I'll just give you a few examples here and you'll know why I'm saying that. It was in 94, sometime in February, I joined Liverpool, and in March, when I was entering Ward 8 at 8 o'clock on Ward 9, where Dr. Anish Vastav has also worked and Ahmed Halawa has worked. So there was a bit of commotion there, and the matron came to me. Oh, Miss Sharma, she thought, well, at the time I was a registrar, so compared to any of them, I was the most senior man. She thought I could really manage it very nicely. Oh, we have a patient who looks very unwell. Please come and see this patient. I said, fine, yeah, let's go and see it. So this patient was vomiting blood, was slumbered in the bed, and there was blood everywhere, and all the monitors were bleeping beep, 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 and there was patient was struggling to breathe, and there was snoring, and there was some gurgling there, and blood pressure, nobody was able to take the blood pressure because you couldn't really feel it properly. She was very obese and slumbered in the bed, and blood everywhere and messy. uh, very unusual to be like that, but it was like this just around the time of handover of nurses. So matron said that, Anne Williams, oh, AJ, come and see this patient. As soon as I saw that, I just wanted to, what was my reaction? I wanted to look for a back door of 9A and run away from there. I'm there to do operations, before that endocrine, I was new to transplant, but still, uh, I'm a surgeon, I should be able to operate. These sick patients, it is not my problem. Anesthetic is there for that. Or some, we call the uh, on-call nephrology team or registrar or the critical care doctors, they will manage it. It's not my problem. But when I was just really looking for the back door, the house officer, in that case, those it will be, they used to be called house officer, intern here, or F1 in current currency. So she was there, about 10, 12 years younger than me. And if you ask her the causes of upper GI bleed, she would tell me 2 or 3 causes. But if somebody asked me, I would tell 10 causes. I'll tell 5 different ways of operating portal hypertension at the time, maybe even now, or another 10 causes of lower GI hemorrhage, all there. But how to manage this, I have no idea. Really, so, uh, but how does a patient of severe upper GI hemorrhage die? You can have severe upper GI hemorrhage in a nephrology patient also, renal failure patients. So what's your name? And what do you do? Oh, sorry. You look very young. You look very young. But renal failure patient. Yeah, yeah. Yeah. Well, I can ask you, why not? We all are. In fact, it is Professor Bhandari says that we are a student for life. We are student for life. And the day you think you don't have to learn anything, that is time to retire. He's about 76. Sorry, deviating again, because mentioning local, this man you need to meet. So I keep getting called once every month or so. He's the exec director of a big robotic firm, and he keeps calling me whenever there's a, the like last time he called me was this data of some million patients, and he wanted me to see how we can use the artificial intelligence in analyzing the critical care data, because just numbers are important, but not everything. How artificial intelligence can help. So I was working with it. So this man has got keenness to learn as much as a high school student has. And at a very young age of 72, he went to Harvard to learn executive MBA in management at a very young age of 72. Anyway, so what I'm saying is that we are students all the time. So therefore, because of young looks, I can ask you. So what is the reason the peptic ulcer disease is much more common in renal failure patients? Yeah, sorry, you don't.
Yes, in renal failure patients, these patients are on multiple pills and also having some gastritis, H. pylori infections because of that. Yes, this way.
H2 receptor blocker came, the incidence of peptic ulcer was terribly high, and they would come with peptic ulcer perforation or upper GI hemorrhage. So this woman was there like this. So she came, this girl, very coolly. Sister, can you please call? Can you get me the crash trolley, please? Crash trolley arrived. Can you please call 222? Call went for 222. Another 2.5 minutes or 2 minutes, 50 seconds. The crash team was there, but those 252 minutes, 50 seconds were quite long for me. But things were happening very smoothly in spite of me being confused. Sorry, I had no idea what is. I thought things went into automatic mode actually, and I was just witnessing that. So, and she asked for. She went there and did suction, and she went did jaw thrust. She left jaw thrust. The snoring went away. As oh, sister, can you give me the Goodell airway? Goodell airway, oxygen on. Please give me one Venflon. Can you please put Venflon, two Venflons? The nurses started putting it and start IV fluids and cross match for blood. A few minutes later, O negative blood was there within 2-3 minutes. And the crash team came. Crash team came. There are big guns there. There's some. There was a registrar. The medical registrar around. There were anesthetic SHO and the whole team was there. But she went to the foot end of the bed and she was the leader. She acquired the role of leader, and she knew because everybody who came knew this girl is in control just by her behavior. And then she was directing them, even though she was the most junior, but she had that dominant role. I said, that is amazing. So this patient was saved, moved to SDU, managed finally, and then she had, upper GI endoscopy for hemorrhage control, brought back, and few weeks down the line she had access, and few months down the line she had transplant. But could she have a transplant if I was there? If I was the only one there? No, we would have lost that patient. How do we? What is the reason for death in patients with upper GI hemorrhage? Maybe I can ask Akshay Kriplani. He's always very clever. Hypovolemia. Okay. Okay. Not your answer is not wrong.
Aspiration.
Okay. Yeah. A and B need to be worried about that. They would die. They will drown in their vomitus. They will drown in their blood, and that's what you need to really do. That some of these patients with massive upper GI hemorrhage, before you do anything in A&E, you need to have intubation for them. But we are not discussing that here. That is not the purpose. All I'm saying is the leadership. On the floor, you are the leader there, whether you are an intern or as the big boss comes, even Professor Anish Srivastava comes. But if I'm sure he sees somebody is taking lead, fine, you take it. I'll just watch you. So that kind of a leadership, that skill I didn't have. Very quickly, I realized that I had serious flaws in my training. Although there were many good things about Indian training, amazing things about it, but that was lacking. And I went for ATLS. Few weeks down the line, I attended CRISP course, critical care course for ill surgical patients. I went for ALS, advanced life support course. And what happened was that just 4 years ago, on 1st July, I phoned my daughter. She was going to start her F1 job. Devina, good luck for her career. She says, Papa, I can't join unless I show the certificate of ALS, ACLS. I can't start that. So these are something very important. Our trainees here are, I can tell you, you all are much more well read than British medical students. But I can tell you, you can leave the word on them and the problems will be sorted there. So even though the person has really done all the exams well, but if you don't show the evidence of their competence, that's what, that Miller's triad, which Professor Halawa mentioned, and I alluded to that, and that's what I'm going to talk about it. And one very important thing in education, you as a teacher, we are lifelong teachers, is you need to link with current experience of other colleagues, and your own experience in other areas, or your experience in clinical or versus in simulation conditions. So we all learn by linking. Okay, so we'll need to come to that. But can somebody tell me what he meant by Miller's trial, Miller's pyramid? Knows how, shows, and does. And that is something which is a competence. So we all need to demonstrate does. And that's what is so crucial. Every year I need to produce the certificate of BLS, basic life support. As you know, I teach trauma in ATLS in UK. I teach ATLS in India to Indian Army. This is the pride the tie I'm very proud of, being gifted to me by Indian Army. Or I do lots of critical care courses in the country. I said, no. You need to show to us, and then only you'll get that. So demonstrating that you can do it, they're not really bother about it. You might be the king of Liverpool or king of Lucknow, but you need to demonstrate that to me. So that's what I'm really trying to do that. So again, I've taken quite a lot of time. This picture, this Akshay Kumar, he's currently associate professor uh, in emergency medicine, but he was a registrar there. I work in tribal area quite a lot. Over there, we realized that I have got many examples. I could give you that, but we don't have time to do that. So once we realized that in such a area where some of our colleagues from my AIMS 82 batch who are topper of that and who started amazing center in central India with very meager resources. And when I shouldn't say they, because for 1 week every year, I'm part of that group, Jan Swasthya Seho. So Akshay said, why not really develop a course based on what we are doing here? So primordial version of that course was in Hindi, and then we evolved into we went to 40 different parts. I'll go to the podium and go through some of the slides quickly. Here, yeah. So when it says surgeons, because when we started this acute critical care course, about 50% of them who attended are emergency medicine doctors. They realized that they need to really gain same skills. So surgeons are not good in identifying and managing unexpected adverse events. So what works is, you know, uh, what happens is that when Sachin Tendulkar uh, finishes the days long hard work there and still he goes back and practices towards the end of the day. So how does he become the best in the world? Repeated practice so that he can play and he can face any pitch conditions, any wind conditions, and still able to really score and perform well. So it is a repeated practice which is so crucial. There must be some reason why 2 out of 10 examiners in final FRCS, of course, it's a degree, but without this, you can't become a consultant. You may be a fantastic registrar, but if you can't pass the exam, you can't become consultant, and you get only 3 attempts for that matter. So, such course we developed because Professor M.C. Mishra, when he was the director of AIMS, he says, "Oh, where is this course?" I said, "This course will cost £850 if you bring it to India per head. We don't have that kind of money." He said, "Develop the course there." So that's what we developed. So it's not lecture based; it is skill development. So what we do is what ATLS would really you can apply in surgical trauma patient in first hour, ACC, acute critical course for what happens beyond golden hour. It has to be interactive. We don't give any knowledge, it's just reorganization of priorities. So this next sentence is very crucial. What is that? So what happens that giving feedback is very important. Whatever teaching or training development you're doing, Giving feedback is very important. And giving feedback is not just another, I've given feedback, no, it won't work. Spoon feeding as Dr. Allah said, it does not work at all. It won't go into health. The person has to reflect. So that's why great Socrates would have said there must be some reason. Life without reflection is not worth living. So as a teacher, we have to reflect. So that's what we have to do as a teacher. We have to help them to reflect, and that is why great Abdul Rahim Khan Khan, the great poet in Akbar's kingdom, he said that Nindak Mere Rakhe is keep the critic with you, honor to reach what, even if you have to give a backyard place in backyard of your house. So keep the critic with you, even if you have to give him a place in backyard of your house. Bin Pani, Bin Sabun, Nirmal Kare Subhai. Without water, without soap, it will make your conduct gentle. So that's what, as a teacher, we have to really develop this skill. I've just said that, but it's a very important skill to help them to evolve into a better and better clinician. It is our duty as a teacher. It is our duty as a trainer. So that's what you have to do. Not, and it is not possible in lecture base. So that's what we do, whether we do online, and that was 7 years ago. I thought, how could you really do online course? I was a really great skeptic about it, and also I'm a technophobe, so I was not keen. But Ahmad dragged me into it, and within 6 weeks, I realized, my goodness, it is such a wonderful way of giving feedback and keep getting engaged. So it's a skill. As a faculty, I have evolved, many others have evolved, and he has helped us. So we are only helping each other to become a better and better teacher, better clinician. Of course, developing, publishing papers uh, is a few more lines, but that's not the reason. But it is nice to be able to show a different way of doing it, which works. Again, inability to maintain airway kills faster than inability to have B, means inadequate ventilation, and that kills faster than inadequate circulation. And the focus on this most important equation, which is what our anesthetist Dr. Rick Dodd says, that delivery of oxygen, which is crucial, you and me survive because of that, is dependent on only on two things. What is the amount of oxygen in blood and how you can maintain that, and how to optimize cardiac output. Time does not really allow me to really talk more details about it, but we need to keep suspecting, keep identifying, make sure that the oxygen deficit is kept as short as possible. Qutub Minar incident, I was in year 1, and Professor Gode, the HOD of anesthesia, was training us in BLS, and he said that 45 kids died there due to stampede, and 44 could have been saved just by BLS. And that Qutub Minar is only 6 kilometers from two huge hospitals, AIMS and Safdarjung, but they couldn't be saved. So ever imagine how their family would really feel. But have we really improved? But not just Qutub Minar. This keeps happening in our huge major institutes anywhere if we don't really have these kind of skills. So even now the consultants of ITU or NSLE say, oh, we get call from neurology ward, please come and put endotracheal tube. Do you need endotracheal tube? Maybe yes, in small number, but most of these patients can be managed by simple airway maneuvers. Even I can do it. So if I can do it, any one of you can do it. So patients don't need endotracheal tube, they need oxygen to survive. And it doesn't come by lecture, it comes by developing skills. We need to quickly finish. That's why we design that manual. We often forget that patients really travel 3-4 days to come to that hospital in JSS, even over here many days sometimes. And once they come, the whole families get uprooted. So simple pneumonia turning into pyothorax, drain there, involving family here for doing chest physio. And that's how we realize that once it is possible to achieve highest quality of scientific care in a remote area, why not in Lucknow, why not in Bombay or Delhi? That is the reason we started this course. Airway, breathing, physiology is not really taught in a way that we enjoy it. I've got sort of pathological interest in it because patient survival depends upon how you understand your physiology and how you really intervene based on minimum intervention. More unwell your patient is, less is the need for investigation. Again, we don't have time to see which Frank Starling curve I have, with Frank Starling or somebody who is referred to cardiologists or medical people. But even in surgical ward, whether it's transplant, urology or nephrology ward, you can very well have patients who would have compromised cardiovascular function. Even those with the history of cardiac disease, they need to have optimization of preload. Nothing else will work unless their preload is optimized. Of course, sometimes it means shedding that preload. Often in a surgical or trauma patient, you need to optimize by giving some fluid. So alternate sensorium, most of the patients in surgical ward, this is one of those season section I had done there a few years ago. And you can see, even before COVID, the place would make sure that you can't really move from patient to patient unless you wash your hands or unless you use that antibacterial. That is another thing, that why do you need saline on day one infusion in somebody who has had extraperitoneal surgery? So that's a different issue. I keep talking about critical threshold. Each case, for example, Amadra was mentioning about 400 cases we have in 4 modules, or 400 articles which we discuss in 4 modules there. Each one of us has, in any clinical situation, should be able to have four, not four, the critical threshold. If I give you the example of, for example, Newton's law of motion, like V is equal to U plus AT, S is equal to UT plus half AT square, and like V square is U square plus 2AS. So with that, you can, laws of dynamics, you can sort any problem anywhere in the world, on Mars, underwater, anywhere, how something is moving, how it is going to behave. If you know the critical threshold of that, bring the problem on and we'll sort it. I know it was not very pleasant for many of us, but I loved it. For example, if I give you sepsis, there are only 4 critical threshold. Suspect sepsis. If you don't suspect, you'll miss it. So that is number 1 critical threshold. Number 2, as soon as you suspect it, make sure within 1 hour you give antibiotics. And there used to be a role of sepsis 6 rules. In elective setting, you give within 4 hours. In emergency setting, you give within 1 hour. Why 4 hours? Give it then and there. If I see a patient was fine in the morning, around round time looks unwell, and I know it is sepsis, I won't expect a SHO to come or a foundation doctor to come and write antibiotic, give it. I'll give it myself. Write it, give it. Takes 5 minutes. Of course, before that, you take the blood sample and send for cultures before you give that. So very important. Give antibiotics. Number 3, make sure that patient's physiology is optimized within 6 hours. Very important. Number 4, do not let sun set or sunrise on sepsis. I've not mentioned any rocket science here. And I can tell you that if every delay of antibiotic therapy increases the mortality by 9%. How many interventions you and me know, which will improve outcome survival by 9%? And for example, if I give you a patient of sepsis with 1 organ failure, mortality 30%. 2 organ failures, mortality 60%. 3 organ failure, mortality 90%. And it moves very quickly. It's a cascade. So that's what we need to really realize, that a stitch in time saves 9. I think I should come to the end of this presentation soon. Communication is very important. I'm giving the example there again. Just because somebody is junior, these are EA5. That's what is there. Making use of the multi-purpose worker in villages. So just because somebody is masters, don't treat everybody, oh, you are subordinate. No. Everybody needs to be treated same. Of course, younger guys would need to have guidance and support. So I don't have time, but that's what I would really keep saying, that we need to really all the time see where, when you give fluid challenge, where on Frank style curve your patient is. So giving fluid challenge means give fluid challenge and go away. See how the patient is responding and behaving. So very important is, so it is all case based. So just one example, like if a patient, any post-op patient or peri-op patient has got VT or VF, you're not going to wait for the cardiologists or medical doctors to come and sort that. You and me have to sort it. And of course, they have got a role to play, but they can play that role only when the patient survives. So some of our patients, like admitted through any, were to be managed by much more intelligent doctors who are medical one, would really be coming there. But there's no way you can say, though, I will never have a patient with, who has gone beyond this flat part of Frank Starling curve. We can very well have such patients on a surgical ward. So that's why you need to really understand, appreciate applied physiology. Time does not allow, but I'll just come to the. So how Dhoni scores whenever he wants. The more I practice, luckier I get. So very important to realize that hands-on experience is crucial. The teaching and training has to be interactive. It is not giving them knowledge, it is how to use knowledge and own responsibility and lead. By giving that example, which I faced in March of 1994, I had to really make a change in my own, the way I conduct myself on the ward as a doctor. Thank you very much. So the next one takes 8 hours, but we'll take only 1 minute.
You can spend 5 or 10 minutes. Director is about to come.
Okay, okay. In that case, I'll continue with that. So, why is it important to really develop critical appraisal of literature? You know, the pharmacists, not pharmacists, the pharmacy company or the commercial company people, they come and show you the papers and they make you. So, but if you are gullible, uh, I used to call the word called gullible, but my daughter corrected, no, for correct pronunciation, gullible, not gullible. If you're gullible, you'll do that. But why? Use your mind, use your training, use your understanding. You do not have to be a great statistician to appreciate what, to be able to analyze articles. So that's what I was saying, that you don't need to be knowing about engines, how to repair that. You just need to know how to drive the car safely and effectively. So that's what is a skill which we develop. What happened was that in Liverpool or at many other places in UK, there were some fantastic registrars, very good registrar, very knowledgeable, known as very, but they were failing in this exam, FRCS. Professor Helawa is one of the examiners of final FRCS. So I said that, applied physiology, 2 out of 10, another 2 out of 10 exam would examine you, they give you article, and then you're supposed to read that and then come and discuss that. So it is like free hit after no ball in a limited overs cricket. So if you've got good practice, you can score as much as you want. And that was from January 1986 when I joined AIMS Unit 3 as a junior in surgery. Professor Ahmed said one thing, that these patients of upper abdominal surgery and thoracic surgery, they die of pulmonary complication, which is the most important infection which kills a patient in a surgical or trauma patient, is lung infection. Antibiotics, zero role in preventing it. Treating, yes, not in prevention. What saves them is physio. Can you give physio to somebody who's got pain? No. You have to achieve pain control. That's what I want all my patients to have: good physio, good pain control, and they'll be going home quickly. That stuck to my mind. Second is, every week you have to present one article. Every week you have to present an article, because you need to have that skill how you can interpret 99% or even more than that articles which are published. It will not make a change in your practice. You need to use your mind to see what is the external validity. Akshay, do you know what is external validity? Yeah, external validity is how you can extrapolate those findings into your own practice. So what is happening in NHS or American healthcare system may not apply here, or may not, what is applicable in SGPJ or AIMS, you can do it, may not really work in, you may have different priorities, somebody coming to tribal area. So what is the external applicability of it? How you explain it into your own practice is called external validity. It's a skill which needs to develop. Of course, that means you need to know what is internal validity. Means how well the research has been done, how well the question has been designed, how the internal and external exclusion criteria are, how well these tests have been defined, has been used, whether the same test which you have really goalposts defined by researchers, whether they have stuck to their own rules because they wanted to go to Japan but they landed in China. That can very well happen. So that is the internal validity, means how well a study has been conducted. So you can really give examples. I try to use sometimes cricketing examples. For example, the two cricketing grounds, I happened to visit them. That was my Mecca, annual, not annual, pilgrimage to the Mecca of cricket, and that is Perth. So null hypothesis, the ball bounce of on a cricket pitch MCG is similar to that of Waka. But if you express it with alternative hypothesis, you'll say the ball bounce on cricket pitch at MCG is lower than that of Waka. But why it is important? Professor Anish Srivastava, do you have just 1 minute to finish it off? Yeah. So why the bounce on the pitch is similar on, if you explain it by null hypothesis, is similar in MCG versus at Waka. And or if you say it in alternative hypothesis, you'll say that it is much higher in Perth. But it is important for especially like somebody like Ahmed Halawa, who is not used to this God's only game cricket. Why it's important? Because you need to really, the captain and the coach needs to know how he plans his strategy, how he plans his game plan and choice of players. That is why it is important to know that. So advanced information. So you do a study. It is this just example of what I'm trying to say. It is very important to know. So you observe, let's say 150 balls each, 35 were too high and 55 were too high in Perth versus MCG. But if the increase sample size to, let's say 1500 each, only 10 times more. So the findings were 350 were too high in MCG and 550 balls were too high above the shoulders in Waka, means Perth. But you can see the difference. This happening just by chance is only 1 out of 100. But just by increasing sample size by 10 times, it is 1 out of 100,000 chances that this is happening just by chance. Sample size is so crucial. Rare the disorder is, you need to have bigger sample size. So these are some of the things which we talk about. In 20 minutes, it is impossible to cover what we try to achieve in, let's say, in 8 hours. So there is just one important example. I thought I sometimes use the lingua franca of India is talking about cricket. So I will finish it off very soon in 1 minute. I don't want to take the time of Professor Dhiman, the director here. John Ioannidis, yeah, it's a Greek name. Is John Ioannidis the correct way of pronouncing? Yeah, okay. He used to be Greek professor and he studied lots of papers, many surgical papers, as you and me, Ahmed Hala was saying. Most surgical papers are blighted by small sample size, and I mentioned that example of ball bounce. Poorly designed protocols, lax standards. They produce plethora of unsubstantiated and misleading research. Why I would, we all like to have our names on paper. Very good. To impress friends, impress colleagues, job promotion. But I'm not trying to say that I'm saintly, I'm not. But one reason I don't want to write wrong things or concocted things is 20 years down, my daughter will say, Daddy, what you wrote is a bit dishonest or, it is not correct. So I don't want her to come and say me 20 years down the line. That's why I've noted. Because each one of us has got different reasons. But of course, he moved to US, but he was criticized for saying that. But okay, I really do not want to take anybody's time here. But I'll finish off by saying this. When I joined, that was second thing which Professor Amankur told me. Look at this A4 paper, which was there in duty of unit 3 there. Cause of diagnosis of identified prostatic cancer. I mean, delving into the territory of Professor Anish Srivastava. That time PSA was not there in January 86. So this was very clear. He said that acid phosphatase in everybody who comes to the door, every male older than 55. So the cost of diagnosing prostatic cancer was something like that, 89,000. But we perform in selected patients with urinary frequency. So to diagnose one prostate case, the cost is this much. But if we perform in those who have got hard nodules on PR plus urinary symptoms, it is much cheaper. The value of a test depends upon which population you are studying. Sensitivity, specificity, positive predictability, negative predictability, useful, yeah, it's not everything. It can be quite misleading. What you need to understand is likelihood ratio. If it is more than 10 or less than 0.1, I think you're talking about a good test. That is what we need to really do that. This is the West Kirby Marine Lake, which is very near our home. Maybe Ahmedallah may have seen. Is it a celestial body which is very bright and shining on the lake? Is it sun, moon? I do not know. It's only small part is shown. So it could be sun, it could be moon. I'll have some more information. Some more information. Oh, the light is lighting in some of the houses. I get different view of the same picture. Oh yeah, there's some cars which have got backlight is on, the street lights are on. So something which look like very bright in this picture could be sun. But as I get more information and some more information, the odds are getting higher and higher. So something which was looking like sun, it's not really sun, it's the full moon shining on West Kirby Lake. So it's a really privilege for me to come back to my home, where 28 years ago our daughter was born. So I'm really very privileged to come here and see my colleagues and most amazing teachers here. So it is very simple. Keep paper in your pocket during coffee time, lunchtime, take it out, and then you can discuss it. And that's how we are really spreading and linking what I said, linking to knowledge of each other, linking what we have learned in simulated area, clinic area. That's how it. And if those who don't have skill, it can be acquired. As I said, neither me or Sabapati, he's a professor of surgery in Sheffield, amazing friend. He used to be a junior resident in PGI, but now professor there. And with him, we developed. He would do 80%, I would do 20% of teaching in that. And it is possible to develop very high quality training program just by, I'm not going to become a statistician in this life, but he's somebody who can walk into any university department as senior lecturer in statistics. But not everybody has to be like that. Even less mortals like me can make some sense out of papers. Thank you very much.